right, thank you everybody for joining us today, both in person and those of you joining us online. My name is Heidi Peltier, and I'm the Director of Programs for the Cost of War Project and a senior researcher here at the Watson Institute for International and Public Affairs. The Cost of War Project was started here at Brown in 2010 and has grown to include dozens of authors from various disciplines and institutions who research and write on the various costs of the U.S. post-9/11 wars, including the budgetary, human, social, and political costs. Cost of War often gets cited for its estimates of U.S. federal spending on the post-9/11 wars, as well as its estimates of the human toll. We're continuing to expand our work on the ramifications of U.S. interventions, including by trying to understand and estimate what are called indirect deaths and other ripple effects of war. These are the deaths and other effects that result not directly from guns and bombs, but indirectly through other pathways such as the destruction of water and sanitation systems, food supply, and various types of infrastructure. One of those pathways is the destruction of healthcare facilities and the targeting of healthcare workers. And that's something that we'll hear about today in Dr. Rohini Haar's talk. It's my pleasure to welcome Dr. Haar, who is an emergency medicine physician and faculty member at the University of California, Berkeley. Dr. Haar's research, teaching, and practice have focused on the protection of populations in crisis. She teaches courses on health and human rights, global health ethics, and epidemiological investigation of human rights abuses. Dr. Haar's research interests include studying the impact of human rights violations, such as torture, violations of free speech and assembly, and war crimes, as well as on health and the protection of health workers and health services in conflict, crisis, and disaster settings. And we are fortunate to have Dr. Haar contribute forthcoming research to the Cost of War Project. In a moment, I will turn the mic over to Dr. Haar. Following her talk, we will take questions from participants, both here in the room as well as through Watson's YouTube channel. For those of you who are following us online, you can feel free to add questions in the chat at any time. And otherwise, please save your questions until the end of the presentation. And with that, please welcome Dr. Rohini Haar.
Well, it's a small group, so I'm not married to finishing any of this and would much rather have sort of an interesting conversation. So I'm going to start us off, but please just stop me and interrupt me, and like we can just have a chat about some interesting issues. Especially, I know now a few of you come from very interdisciplinary fields. So it would be fun to have that mix in a conversation. And that's not always happening on a university campus. It's often siloed, so it would be fun to do that. So as Heidi mentioned, a lot of my work is on the health impacts of conflict. And so today I thought I'd talk a little bit about why it matters, but really about what we can do about it and how complex it is. So my sister is in tech, like everybody in California, and she's like, yeah, what's your TLDR? Which I've recently learned is too long, didn't read. So the TLDR here is that war is bad for health. Well, duh, yeah. War crimes make it worse. Knowing all of that and how bad it is can inform policy advocacy and mitigation. And hopefully what we can jump into a little bit is it's really complex and a changing field, and it requires a lot more action and thought, and both at an academic level, but also at the practice and policy levels. So war is bad for health. Yes, obviously, if you go back in history and look at some of the worst atrocities on record, including things like the fall of Rome at the beginning there, things like World War II and World War I even really stand out in terms of the numbers of people that have died. If you look at that as a proportion of the world population, obviously that's still really, really high. And you're like, well, how did all these people die in a war? It's important to think about the timeline of these things. Sometimes deaths take weeks, years, months, days, and sometimes just minutes. And so when we think about things like of war, there can be events that happen in just a few seconds, like in 5 seconds, 70,000 people died with the atomic bomb in Hiroshima, versus in World War II, over 6 years, 7 years plus, some 40 million people died. So these things can take years or days, just something to think about. So since there's not that many of you, let me just quiz you here a little. What percentage of deaths in conflict are not violent? Like not due to bombs, landmines, guns, bayonets, or airstrikes?
I would guess it's very high. So based on your multiple choice, I'm gonna guess 85%.
What do you guys think? 50 maybe? You might know already. Yeah, I would guess around 85. So when I think about deaths in conflict, I think about, there's accrued mortality, right? Which is kind of the easiest of all of this to figure out. I don't know if they need me on the mic. Accrued mortality is just, as an epidemiologist, you might know, or if any of you on the public health side, but I can't be a professor of epidemiology without saying this, is just the number of people that died between X and Y time. And maybe we can figure that out by death records. But then you need to figure out, well, like, what's the baseline? I mean, some people just die of old age or disease or something every year that would have died anyway. And what's the excess mortality? Like, and that would be the deaths that are actually caused by whatever incident you're looking at. Excess mortality can be split further into potentially direct deaths in conflict, so bombs, artillery, guns, or indirect deaths, so the deaths that are not violent directly from the conflict. And those, of course, can all be split up into civilians or combatants. Direct death, combatants would typically only be the ones with a lot more direct deaths, in theory. In the olden days, though now that's a lot more complicated. And when I think about civilian deaths in conflict, the big things I think about are, is it infectious diseases or is it non-infectious diseases? You can also add under the non-infectious diseases lots of subcategories, right? Like interpersonal violence, chronic disease like diabetes or hypertension, or is it something more urgent, cancer, etc. So I mentioned crude mortality rate, something I might mention a couple more times. So that is just the deaths over a unit time. When you think about excess mortality, that is the crude mortality rate minus whatever we know is the baseline mortality. COVID is a really good example where the crude mortality rate was super high, but if you took out the baseline, the deaths are also super high. So if we say 900,000, 1 million people died in a year, maybe 500,000 of those were dying anyway. And so really the excess mortality is what we want to think about in terms of impact of a certain event or incident or disaster or war. Why would the excess mortality rate, especially from indirect deaths, rise in conflict? I put a few up here. Health workers, like everybody else, leaving. A drop in preventative care, like vaccination campaigns. Restricted supply chains or cold chains being limited, right? So you can't vaccinate as many people or get good medications. Populations moving around a lot. Why would that create worsening health implications? Well, today on the news, it was talking about norovirus in the Colorado River Basin among like whitewater rafters and campers. And if everybody's moving around all the place and new people are coming in, you're just spreading disease on top of everything else. Moving populations also have less access to health services because they don't know which hospitals are around, who's open, who takes what. Things get a lot more confusing. Water and sanitation disruptions can often cause things like diarrheal disease. And then nutrition disruptions, like if you're not eating healthy, can kind of exacerbate all health outcomes. And of course, just generally drop in health services. One big thing I work on a lot is violence against healthcare and health workers, and that's really the major impact of that. Is there anything I'm missing? I think there's probably a bunch, but they all kind of go in a cycle, and it's like a messy, complex chain rather than just all directly leading to it. So here's an example from Iraq, from a study a decade ago. And you can see that injury, conflict-related, is these top bars, and they're really, really small compared to everything else of what civilians died of in Iraq. If you look at direct and indirect deaths in all recent wars, and this is as of like 3 or 4 years ago, actually, I couldn't find a more recent table. That 85% feels about right. Anything from like 63% estimated in some places to 90 plus in South Sudan or in the DRC. So when I talk about the costs of war being health related, it's massive. And again, just to talk about how these studies are being done, they're all over the place. There's no real like one great way to do it, and there's really, really interesting methodological debates going on for the past, I'd say 10 years or more on how you would measure this. And as you know, this can get really, really political. So for instance, one easy way that you think that you would measure things like death or disease is surveillance studies, right? Like in the United States, what we do for COVID is you have surveillance. Hospitals have some diseases that they report on, the CDC or the Departments of Public Health report on all of that. Well, a lot of that would break down if you're in the middle of a civil war. So that surveillance is restricted, or it moves to a different group that kind of has access, but it takes years for that to happen. One country I work in very closely is in Syria, and I'll show you a study later, but basically there was no surveillance of disease from 2011 to 2015 because everything was broken, and it took years to get that surveillance back. Vital statistics like, going into a morgue and seeing how many people died, or going into a hospital to see how many people were born, also breaks down. So what we end up with is some kind of novel things like cluster sampling. So going into a place and doing a couple clusters and seeing what happens, seeing what those clusters show and telling that as the story of the whole place. Now, obviously, that gets really complicated if your cluster is not representative of the whole. So a couple studies in Iraq were criticized heavily because, one of the clusters that they sampled was in Mosul, where there was a lot of violence. And they balanced that out against like other studies, but when they came out and said, 400,000 people died because of the US bombings in Iraq from indirect deaths, President Bush came out and said, this is a load of garbage, this methodology sucks. These days, I see a lot more of what we call social media reporting or incident reporting. So this happened in Iraq as well. There's a website that was quite famous called Iraq Body Count that tried to do this based on newspapers. But now in 2022, this has gotten way more savvy. So we have groups like Insecurity Insight who use social media reporting and news reporting and can use machine learning and artificial intelligence to capture all of that data really quickly. So not an individual scrolling every single thing all the time. But then verifying those incidents is really, really hard. And there's a huge reporting bias. Because if someone dies and no one tells you about it or reports it, it'll never be counted. So I guess my argument is that we are kind of guessing here, and really that you need to triangulate multiple methods to get it right. These are kind of some of the pluses and minuses of some of those methodologies I suggested. So retrospective cluster surveys can be during or really after, but there's issues with insecurity, with recall bias. The statistics are complex to extrapolate that to the entire country. And there's a lot of unknown causes, like people don't know why their cousin died. Prospective surveillance is really hard because you need stable populations to do it. Multiple data sources is really dependent on having primary data to comply with all of this. And then, of course, social media surveillance has its own limitations, though I see a lot more of it now. Social media surveillance also tends to be a lot cheaper because you're not flying people in and having to house them for weeks to do studies. So that's another reason why we see it so much more now. I didn't want to show a picture of anyone who died, but I did want to tell you that while I think it's really important to know what the numbers are, sometimes it almost doesn't matter. Like, one kid is enough that this happens to. And this is a child in Syria, where I met the physicians who take care of him, but he was in the back of an ambulance because of an airstrike on a health facility. So, war's bad. Yeah, of course. War crimes make it way worse. As I said, I do a lot of work in Syria, and so I've gotten to know a number of physicians who either continue to work on the issue from Turkey or elsewhere. And this is Dr. Nasser Al-Mawish. He said I could use his name because he wants to tell his story. Staying anywhere in Syria was a death sentence. It was hard enough to work long hours for continuous days, managing the trauma of my people with minimal supplies, but doing all that with no security was an impossible situation. I left my country, my family, and my beloved profession. Dr. Al-Mawish was from Raqqa, so he first experienced attacks on healthcare by the Syrian regime, then by ISIS, and then finally by the US government. And this is kind of a picture of what that city looked like right after, from the Washington Post. Here's another a hospital administrator I talked to from Syria as part of some interviews we did. But then the airstrikes began. It was clear from the sky that this was a medical facility, but it didn't matter to anyone. We tried to put people in the basement, but bombs can damage everything, and people didn't feel safe anywhere. And then here's a physician in Sudan we talked to for a Physicians for Human Rights report we wrote in 2019. If I'm completely honest, every time I participated in the protests, I was terrified that something would happen to me because I'm a doctor. Doctors were being targeted for organizing a lot of the revolution. But I didn't want to be selfish. I wanted to participate because I believed in what's right for my country. Insecurity Insight reported so many attacks on health in 2021. And of course, this doesn't include the 500 plus attacks on health in Ukraine that we've seen since February, or any of the ones in Myanmar that we've seen in this year. But 43 countries, over 1,000 reported incidents, at least 144 health workers that were either killed or severely injured, 182 facilities that were either closed temporarily or permanently, and at least 137 ambulances. And that's from a report, actually, it's not forthcoming anymore, it came out, from the Safeguarding Health in Conflict Coalition out of DC and Insecurity Insight in Geneva. Another example of why understanding war crimes matters is a study that, are any of you undergrads? So an undergraduate of mine at Berkeley did it. I think she's in law school now. And in Boston. And so she looked at reported civilian casualties online. Okay, so in the blue bars, you can see like the number of reported civilian casualties in Syria from 2011, March 2011, up until 2017. What does that story tell you? What do the the blue bars tell you? Yeah, the story tells you that it's really bad in 2012, and then it looks like it kind of flattens out, right? Well, if you read the news, you're like, yeah, 2012 was bad, but like 2015 and 16 were way worse. The Russians got involved. Why does the civilian casualties not tell that story?
Well, this is what's reported online, right? So
It's reported.
So where it's being reported is what's the bias behind the reporting? Like who is interested in the reporting?
Yeah.
Right, and then public interest wanes over time, especially in long-term conflicts.
Exactly.
So the reporting, the specifics of the reporting would then start to lessen.
So that's exactly right. Reporting bias, but then also if you remember, in 2014, there was a massive refugee crisis because tons of people left. And also, as we said, surveillance drops because there's no one around who's like sitting there recording how many people are dying in every city or every bombing. And so I wouldn't say that it's wrong. I would just say that we can't tell how right or good it is. And human casualties are really, really challenging because people move around a lot. You know, we bury our dead or sometimes cremate them, and looking at that after the fact, weeks or months, can be really challenging and figure out how many people died in anything. So what we did was also compare that on the same timeline to attacks on healthcare facilities in Syria. And that data came from social media reporting and field reporting that Physicians for Human Rights did. And they have this really cool map called Anatomy of a Crisis. And so we pulled all of this data painfully and manually from that website for every month and laid it on top for the same area in Syria, northwest Syria, and I think actually this was all of Syria. And that tells a really, really different story. I can give you all kinds of R-naughts to tell you, but I think you can see that this idea that violence in Syria kind of petered out after 2012 doesn't play out when you look at attacks on health facilities. Sometimes those are easier to tell, right? Because it's an actual facility, so you can see if it was bombed 2 weeks later. You can see damage, people can go report it, and you can take pictures of it. And I think it shows that in 2016, in October, November, around then, is when the violence against health facilities really peaked after Russia got involved.
Yes, so I'd be interested, and I'm not trying to take you off.
No, please. I love it.
But in mirroring the large peaks, so in 2014, in March, it looks like, there's one in March of 15, and then again in 16, as you just discussed, with changes in the context in Syria as to where those were. You know, and I'm not trying to make excuse one way or the other, but certainly ISIS has a different level of concern for healthcare facilities than, say, the U.S. government, just like Russia in their doctrine would have a
actively targeted health facilities.
Right, versus, you know, potentially the Syrian government, who was potentially targeting the same areas, right? And so the reporting lands perfectly. It's just, I'm really interested if you also have a.
Can you disaggregate this?
Yeah, is there a way to see those peaks in context to what happened in large?
So we tried. The issue is, I'll show. Okay, so I tried for years, and we published this paper recently in 2021 with our analysis of trying to disaggregate that. So thank you for teeing me up. And so what we did is, so then I was like, there's no methods for doing this, right? Like nobody's like getting a PhD in conflict epidemiology right now, so it's sort of fun and interesting, but also really complicated and novel. So I brought on a data scientist who works on machine learning models, Evan Mazal, who's now at Stanford, because I didn't know what I was doing, and there's no epi methods for analyzing this really, really messy data. But Evan is not an epidemiologist, he's a data scientist who studies really messy data. And so what he used was a system called multiple correspondence analysis, MCA, basically using 5, 10 different methods, which are all weak in their own way. But if you combine them, you can kind of get a really rough analysis of what's going on, what's consistent over those 10 dirty ways of doing things. And so when we ran the MCA on sort of disaggregated data on civilian violence in Syria, and this includes attacks on health, but also attacks on other civilian facilities and people, this is what we got. And you can see that it's super messy because all that gray stuff is all in the data as well. And when you see things tight together, that's when you can identify that there's associations in it, in these 8,000 rows of data on each civilian incident. And the main sort of associations we found, and the closer things are, the stronger those associations are, very roughly, was Russia identified as a perpetrator in 2016, especially for violence in Aleppo, which matches completely with what we know about the conflict and when Russia got involved. The Syrian regime attacking healthcare across the board, not necessarily affiliated with time, but being associated with attacks on healthcare throughout the data set. And a very tight association, but in a narrow time frame, of the US coalition's attacks on civilians in Raqqa in 2017, which makes sense. And again, it's really messy, but these associations not only make sense with the data, but also with the news.
Does that data set have numbers of casualties, or is that kind of a separate dimension that you can't track, you can't map this way?
So UNHCR stopped documenting civilian deaths in Syria in 2014, said, 400,000, we don't know. Mostly because it was very politicized, and also because Russia's a UN member state, as is Syria. So there's a few like civil society groups that document civilian casualties. So this data is from Violations Documentation Center, I think, VDC. And even now, these data sets are even harder to find these days. I mean, yeah, civilian casualties are really hard to map on this. So, of course, there's there's war crimes that affect people in the immediate sense, but then those have impacts far beyond the immediate. And this is just, as a doctor, I think about increased morbidity and mortality. And when I think about what attacking healthcare, what happens to healthcare facilities and to health in general when that happens, this is just a touch of it. So breakdown in health infrastructure, lots of health needs consistency, regular visits to check on your baby or, your blood pressure or diabetes. So all of that breaks down. There's limited health service capacity, so when you get sick and you go in, there's just not that many people there to treat you. And so you might get lots of people coming in, but the quality of that care decreases and people's access to care decreases. And this is a big one that's not well studied, but I see it in almost every qualitative interview I do, is that there's a fear of seeking healthcare services. Like if you know that hospital could be bombed, like why would you go to it unless you were going to die anyway? And that plays out in interviews we've done in Myanmar, in Sudan, and especially in Syria. And it's really, really hard to measure from a quantitative perspective, like what you're missing in people who don't even seek access or come really, really late. And on that sense, I would say an attack on one hospital that goes unaccounted for or impugned is really an attack on all hospitals, because if your neighbor's hospital gets attacked, like people are much less likely to go to the one nearby as well. That could be next. I mentioned a study on measles that we did last year with a medical student. So between 2001 and 2011, we identified, WHO has 11 cases of suspected measles in Syria in 10 years before the war, 11 cases. Between 2011 and 2015, there's no data because no one's doing surveillance. And then between 2015 and 2019, when my colleagues at the Assistance Coordination Unit in Gaziantep did surveillance, there's 30,000 suspected cases of measles. And I'll just let you sit with that number for a second, because measles sucks. It's really painful, and you get sores, you get rashes, you get fevers. I had measles as a kid in India, and I just remember being so itchy. And, most people recover, but it's highly unpleasant. And in cases where there's malnutrition and other issues, kids die. So that second point is really that we must see the problem to work on solving it. And if we don't see indirect deaths and health impacts of war as a problem, like how would we ever talk about it or think about it? And that really violence on health has impacts far beyond the immediate. Okay, this one I'll go quick. Knowing can inform policy advocacy, mitigation. That's for all of you to do afterwards. And really, when I talk about, knowing the problem, that's documenting attacks and health impacts, reporting that, speaking to folks like you so that you know, characterizing it so that it's sort of understood what the causal pathways are, and then investigating so that we know who did it and whose fault it is. And why? Well, in all of human rights work, there's 3 big causes. It's kind of always the same to me. Promoting accountability, that's like getting the bad guys. Prioritizing resources. So if you know who's most at risk or which regions really suffered the most, then you can prioritize resources and programming to go there. And hopefully, and this is a big hope, you prevent atrocities in the first place because more people know how bad it is for everybody. And then I kind of wanted to just have a discussion because there's some really interesting stuff going on in the news right now. And I'd love all of your feedback on this. But really, thinking about war and health is a really ever-changing, complex field. Another big field I think about a lot is like the ethics of working in health in conflict zones, primarily for local health workers and how challenging it is, but also for other groups, for military health workers, for humanitarians, like international humanitarians, and for researchers like myself. So when I think about that, there's lots of really complex issues. The role of the physician as an advocate, which, in peacetime, we really idealize. But in war, it's like, well, you're not neutral. Working with exacerbated resource limitations and how challenging that is, like making triage decisions when you're not able to do it. Military medicine, personal risk management, like when are you willing to go out there versus not, and managing patient risks is really tough. The moral distress, do you know what that word is? Like wanting to do something, not being able to. It's a term that was coined, I think, in Hopkins in the past 10 or 20 years around the struggles of nurses in this country, but applies even more in those settings. Do you report inhumane treatment and abuse? We'll talk about that in a second. Task shifting. Well, I'm a nurse, but there's no one delivering babies, so should I just do it? Better than no one. Cultural challenges, especially for international workers. And of course, politicization, really, of impartial health services. So this was in the news last month, and I see it even more now. So the New Humanitarian, which, if you're interested in conflict, is a good newsletter you can get way too often, but maybe once a week. And a bunch of Ukrainian folks at the Ukrainian Ministry of Health came onto the podcast, and I think it was an article as well, and they said, what is the best humanitarian aid for Ukraine? It's weapons. We don't want health care. We don't want your medicine. We don't want all these ICRC doctors coming here. We really just need weapons. And then 3 weeks later, Pope Francis goes, it's arming Ukraine can be morally acceptable. What do you guys think? This is in the news today, right? We're like increasing how much we're arming Ukraine.
I'll bite.
Let me drink water.
Yeah, no problem. I guess it's about the time span by which you're making a decision on whether or not this is good, right? So you can, the best way to prevent deaths is not to be at war. But if you are at war, then the shorter that war is, ideally, the longer, the less deaths are going to happen, right? And I'm not going to speak for the Pope, but my guess is that when looking at this on a balance, it's less about a time frame of this war from his morally acceptable, and whether or not this motivates future conflicts of this particular type. So, case in point.
He did say, and I didn't use this was from the New York Times, there was another headline in Reuters that said, "For defense."
Yeah, so, so it actually would go hand in hand with what I was about to say here, where if the conflict started because one country invaded another and then there was deaths because of it, if you allow that to be acceptable, that you can invade another country, right, without saying, no, we're gonna defend against doing this, then it would potentially motivate someone else to do the same thing again in the future. So, on balance, is it worse to give weapons to continue this particular conflict, to say, look, there's a cost when you do this, or is it best to say, no, we need to end this as fast as possible in any way, shape possible, right?
So you bring up, I think, a few interesting points. One is, when we think about like international humanitarian law, like we mostly frame that around the Geneva Conventions and Henri Dunant and, you know, all of this stuff that says war should be proportional, that the impacts on civilians should be limited, that certain things like bombing hospitals or attacking civilians really should be, or bombing hospitals should be banned, attacking civilians should be proportional and limited and targeted. There's a whole nother theory of thought. There's a civil war. You might know this. In the Civil War, there was another set of rules that we had in the United States, and there's an institute in the military named after him.
Lieberman's.
The Lieber Code.
Yeah, the Lieber
Thank
Code.
you. And I think there's, well done. And there's a Lieber Institute. So the Lieber Code actually took a really different approach. It was very much at the same time as Dunant.
Yeah.
And my mentor and colleague, Len Rubenstein, wrote this great book that he talks about this, where the Lieber Code really doesn't say that anything should be banned, that if it's a just war, and I would argue everyone thinks their war is just, if it's a just war, and you can, you know, limit the extent or like the extent of a war and end it quick, then anything goes. And while I think most of us say IHL has these strict rules, the undercurrent of international law is just that, is essentially the Lieber Code.
I mean, I would argue that it's not. Sorry, I would argue that it was more of the for IHL and for Henri Dunant, it's more of the realization that war is a part of life, and unfortunately, we have not come up with an alternative to it. We dive into conflict.
We're always going to have wars.
Yeah, we always have. So given that this is something that is habitual and we try, as much as we try not to do it, we still do it, let's put limitations on it. And I always say that IHL is guardrails. Like, in the worst of our humanity, how do we try to still ensure that life continues? Whereas for like the Lieber codes are more just like, this is your, I don't want to say like, but it's almost like a religious charge to continue with your good fight. And it allowed for a lot of things that we now say is not acceptable, period, in warfare, even if you want to have
We say it, but we still do it, you know? And I think that's really the tension here, because what I see here is that we're like, well, yeah, if we end this fight quick, like, maybe overall the total number of deaths would be less. I have a whole bunch of other questions about this, and I haven't decided what I really think, because I think it would be worth a paper, but Heidi, I'll propose that to you next month. But really, will it prevent deaths and illness? Would throwing more weapons, which we are doing, like, end this war sooner? I don't know if that's clear. And then we talk about the good guys being more likely to win, and I think we all generally agree on who the good guys are in this war, but we might not agree when it comes to the next one, or the next one, or the next one, or the next one after that. And I will argue that, I don't know if keeping track of the latest scandals in human rights, but Amnesty International was kicked out of Ukraine. You're better than I am, but in July for reporting that the Ukrainian government was also violating human rights, effectively using sometimes hospitals for military purposes, which is also banned by the Geneva Conventions, and not necessarily using civilians as like shields, but putting military in civilian areas, which is a violation of international humanitarian law as well. And then Zelensky was like, "Oh hell no," and they can't work in Ukraine anymore.
They were also documenting violations when it came to POWs, and the fact that there are very little to no Russian POWs in that conflict, so what has happened to them. But they were the only major organization publicly and openly doing that. So
I talked with a friend at Human Rights Watch who was like, well, they also reported the same thing, but they framed it differently. So it's complex and ever dynamic and changing. And then really, in terms of this talk, I think at what cost and who's the cost to weaponize, because if that's to civilians anywhere, like, are some civilians better than other civilians when it comes to being killed by weapons? And then the big one to me is like, what's the unintended consequences? The other question I would have is like, who's doing the arming? If it's at the cost of humanitarian aid, by funding that should have gone to aid, that's very different than like, it's a military to military thing and the funding systems for aid are different. But when it comes to the United States, these things are obviously very interdependent. I think I can't ever have a talk without a Karl von Clausewitz quote, I'm sorry. War is nothing but continuation of politics. And really, like, who is it going to? I don't have a clear answer for that one either. But I will say that, you know, when we often have these conversations, like, we're not really thinking about the number of local health workers that are involved in all of these things. We're thinking about like these international policy plays. And then to me, it gets even more complicated because international humanitarian actors like the ICRC or MSF often have a very clear mission of independence. Wait, I wrote it down. Humanity, impartiality, independence, and neutrality. So humanity, obviously they're humanitarians looking out for the best. Impartiality is what all healthcare workers need to have, which is like we treat all comers regardless of who they are. Like in Afghanistan, if you're the MSF hospital, you would treat the Taliban as much as any other civilian or any other military person. And it's really based on your triage and your health and not who you are. Independence, so they work independent of governments. And then neutrality. Neutrality is a big one for these international organizations, right? Because that's how they maintain their ability to work in these settings. They are neutral. We're not participating in the conflict. We're not taking sides. We just help the civilians. Well, that's very naive when it comes to local health workers, because I don't know any local health worker in any country who's neutral. Like, you vote, you should vote, you have strong opinions about who should be in power in your country, right? Like, can you really be neutral? And then if we hold local health workers to these standards that international humanitarian actors have written 150 years ago, like, that doesn't work out. But then how does that play out with weapons as aid? I don't know. Sorry, I'm problematizing this whole thing at the end, but I think it's really where the interesting conversations can sit. Another great doctor wrote about that. Medicine is a social science, and politics is nothing else but medicine on a large scale. And in the United States, you know, I work with a group called Physicians for Human Rights, and a lot of the folks that I admire had a great social mission in the United States or elsewhere, and Versha is one of them. but then you can't really be neutral. I'm going to end with a few quotes that I think are interesting. This was last year. What's happening in Sudan is a total disaster. There are killings every day. There's no freedom of speech, no democracy. The regime is using all its armed forces to stay in power and forgetting what's important, including health and education. So of course these physicians can't be neutral to that. MSF had a really interesting report come out in 2021 called Adding Salt to the Wound about US counterterrorism policy, saying it adds salt to the wound, like now I can't help even when I want to. It was extremely risky to provide any form of medical care to the injured demonstrators, and some of my colleagues were arrested based on rumors that they helped civilians. Because we have, US federal code, I don't remember which one, says like you cannot provide material support to terrorists. But then if you work in Afghanistan, Iraq, or Nigeria, it's really hard to prove all the time. I think I'll end here. So one project that we're working on is in Myanmar with health workers there as part of the civil disobedience movement. So there was a coup in 2021, tell me if I'm boring you. And since then, health workers are one of the main groups that are being targeted because they started the civil disobedience movement. So they left their government posts, government salaries, and often moved into the villages and hills and are being attacked from all different ways. Arrests, there's been a few airstrikes, and killings of health workers as well. And we just finished a project interviewing a number of them, and I'll share that soon. Okay, that's all I have for you. Thank you. And then, I don't know if there's questions, but I'm really curious to hear what all of you think as well, and what you work on.
So I actually have a question. You've mentioned like both quantitative and qualitative, so like mixed method studies.
Yeah.
Given your research portfolio, like what types of impacts have both of these data had, both within the fields and in practice? Thank you. I was asking about mixed methods research and sort of the impact that these different types of data have had. Like I know you did a qualitative study in Myanmar, and sort of how do you make those decisions?
That's a really good question, and I can't say I always hit the target, but I think so as a human rights advocate, like human rights groups often tell the story, right? Because one story can kind of show like a human story, like an evocative example of what happens, and the sweet spot there is showing the story and then giving the scope and scale. So my experience being between a human rights center and a school of public health is that my human rights center often does too much storytelling, and that my school of public health just dry as bones data.
Yeah.
And that the sweet spot in between is to really give those examples, but then also show that this isn't a unique problem and that it's massive and this is the level and this is the characterization of it. So I try to do that in a lot of reports, but also it's so dependent on that, but these days it's also dependent on the funding you can get for a project and the access. I couldn't do a quantitative study in Myanmar even though it's massive because I have no access outside of some WhatsApp numbers.
I think my voice projects, but I'll hold the microphone. You're fine. I had several questions for you, but I'll try to limit myself. I'm going to ask that you go back to the slide where you highlighted 4 of the 7 humanitarian principles, and ask if you think, because the 3 that are missing are voluntary service, unity, and universality, if they answer some of the questions that you posed on the difficulty of being a national staff member and being held to these principles.
I saw an interesting interview last month about solidarity, and I think that kind of fits into that, like, unity, independent, voluntary service, and
Universality.
universality, which is like, I think that kind of falls into the humanity. I think for the local health worker it does. My experience is that humanity is even not like one of the top ones. These three are like the ICRC principles, and they're the ones that are touted as the supreme, and that the trickle-down effect on local organizations is that they're expected to comply with this. And so the other ones, solidarity and unity, are sort of erased a little bit in that, or, washed away a little bit. So I think, having those conversations and being like, hey, there's a couple more, would be an interesting way to like change the norms around it.
I'm going to ask a follow-up question.
Yeah,
Going
unless
back to that.
I think some of you might have answers to that as well. I don't know if I did a good job.
I think it's a very valid point. My background is in IHL, hence why I knew the Libra code. But the question that you had about, the slide that you had about international staff versus national staff and just the numbers, when I was in Switzerland a few years ago, we actually looked at the numbers behind insurance policies, protection measures, safety protocols when it came to their contracts. And I think that's a very interesting thing that you should probably look into for future research, because then it gets very legal and very interesting, and you start to see the imbalance when it comes to the power between being a non-citizen versus a national, which is not the case in almost any other context when you're talking about being a civilian and operating in another country.
So it's, I remember when I was in the 90s, and I'm going to date myself, but in the 90s I did my first like big international project, and I was in Ethiopia, and that was the first time I saw like how much my national staff got paid versus me as a college student got paid, and like the insurance I had to get, and sort of the security protocol, like I had to check in when I was out in the field like every day on a satellite phone, whereas the local guys, like no one's checking up on them. It doesn't sit right when you're like working hand in hand with people and you're treated so differently. But I hope that's generally a trend that I see. There's a balance to that, right? Because another thing that I see happening is like when you try to equal the salaries among national and international staff, it can also be problematic, because then like these international organizations can outpay any local health ministry or hospital job, and they just brain drain the whole thing. So I don't know if there's an easy answer to it.
I haven't found one, but I've seen a lot of organizations are now giving their national staff the opportunity to become international staff, and so you're seeing a migration of people who have these vast amount of experiences being able to take their personal experiences and go into another conflict. And it's working when it works. That's all I'll say.
Yeah.
I'll ask a question here. Is this my phone? Yeah. I'll ask a question here, which is about how to. That's not on. There we go. Green light. Which is how to protect healthcare workers and protect access to healthcare. And obviously reducing war, reducing bombings of healthcare facilities. But this brings to mind questions you raise about do we send more arms to Ukraine? It also, for me, raises the question of, do you give guns to teachers? Now, personally, I don't think that's the right approach. We probably don't want to give guns to healthcare workers. But what approach could be taken, or what approaches could be taken, other than potentially, or in addition to potentially, prosecuting for war crimes for bombings of healthcare facilities? So if you could say a little bit about what potential responses or strategies could be pursued.
So to start broadly, I think, like, you point to the big weakness in human rights, which is that we rely ultimately on, like, a name and shame game. Sometimes we don't even name and shame because, you know, the WHO has a great list of attacks on health all over the world, and it doesn't name the perpetrator. So I would say step one is to get to that place where we're actually naming and shaming folks. And as Hannah Arendt wrote 50, 70 years ago, the real weaknesses of that are A, if people like aren't in a government that, you know, if they're stateless, but second, if the government that you're naming and shaming is shameless. And ultimately that's kind of what we're dealing with, whether it's Myanmar or Russia right now or Syria. And so I think there's like this huge gap and weakness there. To me, like, we haven't hit the low-hanging fruit yet of like doing a good job naming anyone at an international level. And then I think that's for accountability and for limitation, and I don't have great solutions for how to get there. So then a lot of the research now is on like mitigation and protection. So not arming healthcare workers per se, but I guess just like identifying which groups are most at risk and like funding them. Like the group I work with in Syria, the Syrian American Medical Society, did a ton of work like putting hospitals in caves, sandbagging facilities, moving to basements. And it's this like cat and mouse game where they would do that and then the Russians would have bunker busters, you know, and I think at some point like funding kind of dried up for all of those activities. And I'd say like that's where I would double down. I don't know. I need
Thank
help
you.
with that answer if anyone has a good idea.
I'll just bring our attention to the time. It's a couple minutes before 6. So if there's another last question or maybe two, and then we can wrap up.
We didn't have a chance yet. Sorry. Still. Well, mine is more of a procedure, I guess a process-wise. I thought your presentation was outstanding in being able to highlight a story and tell a reason why the change was required. And I was wondering how you prevented goal substitution in your research, where the seeking accuracy and being the most accurate about the numbers of deaths, for instance, from this, perhaps steals from the goal of highlighting the problem and then seeking a change in action.
That's a very good question. I think, well, to all you students out there, I would say like the best way to figure stuff like that out is like good mentors. So mine are the best. And I think like I've always gravitated towards like a fit to purpose model. So like I don't need to know the exact number of something so grave as torture. Like 1 is bad enough, right? Like you don't need an exact number. But for something more subtle, maybe you need more. And so like marrying the data like in your brain always to the policy or action like keeps you grounded in that. Like if you don't have a so what, then like that's just data for data's sake. You're just wasting people's money and time. Also, I'm an ER doctor, so like I have a forest and not trees brain, I think. So I'm like, I don't have time for all this. Like, what am I going to focus on? So, which is work, because it's like underfunded, and like not enough people do it. So you have to prioritize it.
Thank you.
Thank you.
That brings us to 6. So I'm going to thank everybody for coming here today, for participating online and in person. And thanks very much to Rohini for your talk and for the discussion.
Thank you to this delightful audience for, roundtabling this with me.
Thanks, everyone. Have a good night.